Bismillahirrahmanirrahim. There was a popular demand by many of the trainees, including trainees in my department, that you have not uploaded any lecture regarding the basics of dermatology. So I'm going to give a lecture today on introduction of dermatopathology. Then I will again give another lecture in due course of time on inflammatory dermatosis. This lecture I have given to different trainees before, but have not recorded and not uploaded on this channel. So today's lecture is on the introduction to dermatopathology. Well, since it's a very basic lecture, so I would like to start from the very basics. That is the skin is comprising of three layers. The first is the epidermis, which is the most superficial layer. Then is the dermis, which comprises of most of the thickness of the skin, and then underlying the dermis there is subcutaneous fat. So now this slide shows different layers of epidermis. The topmost layer is called as the stratum corneum or the horny cell layer. Then the second layer is stratum lucidum. This is the pink layer which you can see on your screen. This stratum lucidum is present on palm and soles. It is not present elsewhere. Then beneath the stratum lucidum there is a granular cell layer. The keratinocytes here, they have a granular cytoplasm, and hence it is called as the granular layer. Then beneath the granular layer, there is a few cell thick stratum spinosum or the spinous cell layer. And below the stratum spinosum, the last layer is the layer comprising of columnar cells, which are interspersed with the melanocytes. And this is the basal layer or stratum basal. The junction between the epidermis and the dermis is called as the dermo-epidermal junction. The portion of epidermis which protrudes into the dermis is called as the retiridge, and the portion of dermis which protrudes into the epidermis, it is called as the dermal papillae. These are the dermal papillae, these are the retiridges. The portion of dermis which mainly comprises of the dermal papillae and a slight small portion below that is a little compact. You can see the collagen here is little compact as compared to the collagen down below. So this portion of dermis, which is the smaller portion of the dermis, is called as the papillary dermis, because it is mainly comprising of the dermal papillae and a small portion beneath the retiridges. And rest of the dermis is called as the reticular dermis. This is the stratum corneum. This is stratum lucidum. Then stratum granulosum is a granular cell layer. Then stratum spinosum. You can see these keratinocytes have large vesicular nuclei and they are interconnected with each other by desmosomal connections. These are the desmosomes, which are the connections between the cells. These cells in stratum spinosum are polygonal. That is, they have various facets which are interconnected with other cells. In this slide, this desmosomal junctions or intercellular junctions are more obvious. These junctions are perpendicular to the surface of the cells. Desmosomes are more obvious here. Then comes the basal cell layer. Basal cell layer comprises of two types of cells, that is the keratinocytes and then the melanocytes. The melanocytes can be identified by their round and dark staining nuclei and a halo surrounding those nuclei. So usually one melanocyte is interspersed between 5 to 6 keratinocytes. These are the retiridges, the portion of epidermis which is protruding into the dermis, and this is the dermal papillae, the portion of the dermis which is entering into the epidermis. The dermo-epidermal junction is very important because most of the sub-epidermal blistering disease are because of the defect or antibodies against any of the antigens which are present at the dermo-epidermal junction. So this is advanced form of dermatopathology, and I'm not going to discuss I've already discussed these different antigens in my previous lectures. This is the main dermis. You can see the difference between the two type of dermis. The superior dermis, or small portion of dermis, the collagen is compact and it is called as the papillary dermis, and rest of the dermis in which there is the collagen is thick and in loosely arranged is the reticular dermis. The collagen in the dermis is formed by the fibroblast, and the fibroblasts usually have spindle-shaped nuclei. So if we do the special stains, this is the special stain for elastic fiber. Elastic fibers are present in the dermis, but they do not comprise of the main thickness of the dermis. But these are important for maintaining the elasticity of the dermis. Elastic fibers are highlighted by elastic von Giesen stains. And in case of disorders in which the elastic fibers are distorted, you can see the fragmentation of these elastic fibers, and they will not be seen as black long rods or chains. Rods or fibers will not be visible. Rather, these fibers will be broken down to smaller clumps. This is a diagrammatic representation of different kind of glands. This is the first is the hair follicle, and the glands which are associated with hair follicles. These are the sebaceous glands. They produce sebum and are present mainly in the scalp and the face. In addition to these sebaceous glands, there is another kind of gland which is the eccrine gland or the sweat glands. This is present throughout the skin, including the palmar and plantar surfaces. And these glands, they open directly into the skin surface through the eccrine ducts. There are another kind of eccrine glands which produce special kind of sweat. These glands are called as the apocrine glands. The apocrine glands are the modified eccrine glands, which instead of opening directly into the epidermis are opening into the hair follicle. And the secretions which are produced by apocrine glands, they produce a special scent, and which is specific to a particular individual. So this is the histopathological appearance of a hair follicle. This hole is the hair follicle, and in between the hair follicle, this is the hair shaft, which is originating from the hair papillae. Hair follicle is usually divided into three parts. That is the infundibulum, isthmus, and the basal part. The isthmus is the portion of hair follicle which is between the connection of the erector pili muscle and the entrance of the sebaceous glands, while infundibulum is the portion which is superior to the connection of the sebaceous glands. This is the cross-section structure of a hair follicle. This is the matrix from which the hair shaft originates. This is the hair bulb. This is the blood flow comes from below the dermal hair papillae. Then this is the inner root sheath, and this is the hair shaft and the dermal sheath or outer root sheath. Inner and outer root sheath, and then this is the dermal sheath. Cross section of the hair. The hair comprises of a medulla and a cortex. Then the hair follicle comprises of inner root sheath, the outer root sheath, which is the bigger portion, and the dermal sheath, which is covering the hair follicle. So eccrine glands are obvious here. Sebaceous glands are vacuolated cells that produce decapitating secretions, and they are present. You can see the cells disintegrating and producing sebum, which enters into the follicles that enters into the ducts which are connected to the hair follicle. So you can see here, these are the sebaceous glands, and they are producing sebum. Sebum is produced by disintegration or decapitation of these glands. That's why this is called as the holocrine secretion or decapitating secretion. While the eccrine or apocrine glands, these cells are not disintegrated, but rather these apocrine glands, they do produce the decapitation secretion. The cells, they disintegrate and produce secretion into the cavities, into the ducts, and then taken up through the hair follicle to the skin. While the eccrine glands or the sweat glands, they produce sweat, but the cells, they do not lose their morphology and they remain intact. So this is the eccrine secretion. The eccrine glands, they appear as double layer cuboidal cells in the cross sections and in the histopathology. The intraepidermal portion of the sweat duct appears like this through the stratum corneum. The oral mucosa comprises of the epithelium and the stroma or the corium, and instead of calling it epidermis, we call it as epithelium, and rest is the dermis is the corium or the stroma. This is the difference, the usual difference in the structures in different regions. Sole of the foot is characterized by thick stratum corneum and even thick dermis. Then in nose and scalp, there are abundant hair follicles and lots of sebaceous glands. Forearm and back, the skin is almost similar, which there will be a normal epidermis, a thick dermis. These are the sweat coils, and this is the subcutaneous fat. In scalp, particularly, there will be large number of terminal hair follicles. So number of follicles will be seen in any biopsy section. Now I'm going to discuss one by one various pathological terms which are commonly used in dermatopathology. And these terms will be used many a times once when we are describing different clinical appearances and histological appearances of those diseases. Hyperkeratosis in literal sense means thickening of stratum corneum. And hyperkeratosis is usually seen in conditions like ichthyosis, in keratodermas, in PRP, wart, and cutaneous horns. There are other causes in diseases in which the stratum corneum is thickened, and all the conditions in which stratum corneum is thickened are called as the hyperkeratosis. Usually, those disorders in which there is thick stratum corneum, the stratum granulosum is also thickened. So hyperkeratosis is usually seen in combination with hypergranulosis. So once the stratum corneum is thickened, the granular layer automatically is thickened. Another term which we commonly use in dermatopathology is the follicular plugging. And follicular plugging means the presence of keratin plugs within the hair follicles. These are the hair follicles opening into the epidermis, and the keratin plugs are seen in these hair follicles. So this is follicular plugging, and follicular plugging is seen in various inflammatory and malignant skin lesions like DLE, like lichen planopilaris, and it is seen in seborrheic keratosis, actinic keratosis, etc. Parakeratosis. Parakeratosis means retention of nuclei in stratum corneum. Usually, the stratum corneum does not have nuclei. The stratum corneum, before the keratinocytes enter into the stratum corneum, they lose their nuclei, and it is only their envelope or the cell membrane which form the stratum corneum. Presence of nuclei in stratum corneum, which we see in parakeratosis, means that the keratinization is not occurring properly. And there are various causes of improper keratinization. And one of the causes is maybe because of the increase in number of cells in the cell's proliferative phase or in cell cycle, as a result of which the keratinization occurs rapidly, and hence we see parakeratosis. Parakeratosis is seen clinically as scales. So whenever you see scales in any skin pathology, skin condition, the histology will automatically be that of parakeratosis. So all the conditions which are clinically characterized by scaling are characterized by parakeratosis. Since parakeratosis signifies some degree of dyskeratosis or abnormal keratinization, usually in thick parakeratotic columns. Beneath the thick parakeratotic column, there is loss of granular layer, which is a typical feature in psoriasis. So parakeratosis is typically seen in psoriasis, which is called as confluent parakeratosis, in which the parakeratosis is seen from one end of the biopsy to the other end. There are other conditions in which the focal parakeratosis is seen, that is not confluent but small areas of parakeratosis, which we see in PRP. In pityriasis rubra pilaris, parakeratosis is alternating with hyperkeratosis. In P. rosea and PLC, on actinic keratosis, parakeratosis is seen as a lens shape or focal parakeratosis. This is hypergranulosis, the presence of thick granular layer, and usually, as I've told you, in whatever condition there is hyperkeratosis, there is hypergranulosis, typically seen in keratodermas, in lichenification, and in lichen planus. Koilocytes are a special kind of keratinocytes which are present in stratum granulosum that are infiltrated by the human papilloma virus. So these are the keratinocytes. These all are the keratinocytes, and the dark pink structures which you see here, these are the viral inclusion bodies. And human papilloma virus produce both the intranuclear and intracytoplasmic inclusion. Rest small pink dots are the granules of stratum granulosum. So koilocytes are the keratinocytes that are infected by human papilloma virus and seen in stratum granulosum. Acanthosis. Acanthosis is a term which we commonly use while describing a histopathological appearance. Acanthosis means thickening of stratum spinosum. Usually, the stratum spinosum is 4 to 5 cell thick. If it is increased to about, say, 9 or 10 cell thick means that if we count the cells in vertical direction, we can say this epidermis is about 1, 2, 3, 4, 5, 6, 7 cell thick. So acanthosis is slight thickening of stratum spinosum, and is usually 9 to 10 cell thick. If this thickness increases to more than 10 cell thick, here you can see it's more than 10 or 25 cell thick, then this is called as the hyperplasia or epidermal hyperplasia. We can call it as psoriasiform hyperplasia. So there are many conditions in which we see this kind of hyperplasia, and the prototype is usually the psoriasis and chronic lichenified eczemas, the keratodermas, and in warts and prurigo and other malignant conditions as well. Papillomatosis is another term which we commonly use. Papillomatosis means the protrusion of epidermis superiorly, that is above the surface, in form of church spire. It's also called as the church spire appearance. Usually the church spires are seen as angulated towers, and this is the appearance which we see in papillomatosis, commonly seen in seborrheic keratosis, warts, and epidermal nevi. Another term that is used is the epidermal atrophy. Epidermal atrophy means the epidermis is thinner than the normal epidermis, and there is loss of reti ridges. So epidermal atrophy is seen in several sclerosing condition having dermal sclerosis, like scleroderma, like LSA, atrophoderma, and LE. Melanocytes are seen in quite abundance here in this picture, and these melanocytes not only produce pigmentation but but increased proliferation will look clinically as a pigmented spot. So if the melanocytes proliferate in a group, then this is called as a junctional activity or a junctional nest of melanocytes, which we see commonly in junctional nevi. So these are melanocytes which are the increased number of melanocytes in form of a junctional nest. Epidermal necrosis. You can see here there is stratum corneum, but the definition of keratinocytes is totally lost. Rather, the keratinocytes, there is no cell wall, there is no cell nucleus, and everything is in a form of a pinkish amorphous material. And this is called as the epidermal necrosis. And epidermal necrosis is commonly seen in Stevens-Johnson syndrome, toxic epidermolysis, acute graft versus host disease, in pemphigus paraneoplasticus, and necrolytic migratory erythema. These are the common causes of epidermal cell necrosis. Spongiosis. Spongiosis is a prototype histological appearance seen in eczemas. Spongiosis is intercellular edema, that is, the water is seen in between the keratinocytes, and because of the presence of edema between the cells, the desmosomal junctions, they become more obvious in spongiosis. This is a crust. Crust comprises of serum and neutrophils, and the crust is seen in many conditions in which there is exudate, particularly conditions like eczemas or impetigo, and the exudate then dries and form a crust, which is mainly comprising of serum and neutrophils. Exocytosis. You see, in spongiosis, because of the intercellular edema, the spaces are created between the keratinocytes. And in these spaces, the inflammatory cells can enter into the epidermis. And the presence of inflammatory cells in the epidermis in the condition of spongiosis is called as the exocytosis. And exocytosis can be a lymphocytic exocytosis, it can be neutrophilic exocytosis, and it can be eosinophilic exocytosis. Whatever is the cell which is entering into the spongiotic epidermis will be called as the exocytosis. MUNRO abscesses. MUNRO abscesses are small, tiny abscesses comprising of neutrophils which are seen within the parakeratotic columns. If they are seen in hyperkeratotic areas, this will not be called as the MUNRO abscesses. For MUNRO abscess to be called, these abscesses need to be present within the parakeratotic column, and it is a prototype of or characteristic histological condition of psoriasis. Then there is another condition which we use, and it is called as the epidermotropism. Epidermotropism means the presence of atypical lymphocytes within the epidermis. And this is different from exocytosis in that, number one, in exocytosis, the lymphocytes that are entering into the epidermis, they are of normal size and shape. And number two, these lymphocytes are present with spongiotic epidermis. While in epidermotropism, the lymphocytes that are present in the epidermis, number one, they are abnormal in sizes and shapes. And number two, there is no spongiosis. So it is, that's why it is called as epidermotropism, that is the extreme love of epidermis. These lymphocytes, they enter or make their own spaces and enter into the epidermis. And these lymphocytes, they can be clearly identified from the keratinocytes in that the lymphocytes will not be having the desmosomal junctions with the keratinocytes, and there will be a small halo surrounding these lymphocytes. And if these lymphocytes are present in some clumps, then it is called as the PAUTIRIER microabscess. A spongiform pustule of KOGOJ is a typical histological appearance of psoriasis. In a spongiform pustule of KOGOJ, you can see a neutrophilic abscess, a large neutrophilic abscess in superior layers of the stratum spinosum with slight degree of spongiosis. So if you say there is no spongiosis in psoriasis, it is wrong. In a spongiform pustule of KOGOJ, there is a little bit of spongiosis, but that is restricted to superficial layers of stratum spinosum, and along with spongiosis, there are neutrophilic abscesses. Colloid bodies. Colloid bodies are degenerated or dead keratinocytes which are seen as clumps within the upper dermis. And colloid bodies are seen as a part of interface dermatitis. In interface dermatitis, there is degeneration of basal layers, and these degenerated basal cells, they fall down into the dermis in form of colloid body. This is a subcorneal blister. In several sub-blistering disorders, the serum or inflammatory cells may be seen below the stratum corneum and sitting on the normal looking epidermis. So subcorneal blister is seen in subcorneal pustular dermatosis, in pemphigus foliaceus, IgA pemphigus. This is the epidermis is seen mainly on the roof of the blister, and the floor of the blister is formed by a layer of basal layer, and this kind of blister is called as the suprabasal blister. Acantholysis is the term which is used for the loss of desmosomal junction connections between the keratinocytes, and these keratinocytes, they are entering into the blister cavity as round cells because these keratinocytes, they attain polygonal shape because of the presence of desmosomal connections. And when the desmosomes are lost, these cells, because of centripetal force, they assume rounded shape. And these rounded keratinocytes are called as acantholytic cells. So the acantholytic cells and acantholysis is seen in pemphigus group of diseases like pemphigus vulgaris, pemphigus foliaceus, Hailey-Hailey disease, Derrier's disease, Grover's disease. This is partial acantholysis or dilapidated brick wall. You can see the epidermis is there. There is no big blister, but the keratinocytes are seen disintegrating and falling apart. So this is partial acantholysis, which we see commonly in Hailey-Hailey disease. This is a little bigger blister, and the blister here is below the epidermis, and it is called as the sub-epidermal blister, and the dermal papillae are seen protruding into the blister cavity, and this protrusion of dermal papillae is called as the festooning of dermal papillae. Why is this festooning seen? Because of the blister, the rete ridges which are occupying this place, they are pushed up. Because of the subepidermal blister, the papillae are left and rete ridges are pushed up. So you see a subepidermal blister and festooning of dermal papillae. And once you see a subepidermal blister, then it is your duty to find which kind of inflammatory infiltrate is seen within the blister cavity. And I have discussed this in detail in my lectures on the pemphigoid group of diseases. This is a papillary tip microabscess. This is a dermal papillae with neutrophils, and the papillary tip microabscesses is prototype of dermatitis herpetiformis. Chorons. Chorons are the dyskeratotic cells, and dyskeratosis is a common feature of Derrier's disease, of Hailey-Hailey disease, and Grover's disease. So chorons are seen in the stratum corneum beneath the follicular plug, which we commonly seen in Derrier's disease. And these chorons, these cells, they appear as disintegrated nuclei and a halo surrounding these disintegrated cells. Granuloma. Granulomas are one of the common histological finding of granulomatous inflammation. The granulomas are comprised of collection of epithelioid cells. Epithelioid cells are the histocytes which have engulfed the various antigens, and in the process of phagocytosis, they have developed an enlarged or elliptical nuclei, and the collection of these epithelioid cells make up the granuloma. And granulomas are of different types. They are tuberculoid granulomas, they are sarcoidal granulomas, they are necrobiotic granulomas, or suppurative granulomas. Granulomas may be seen surrounding the nerves, and these perineural granuloma is a typical feature of tuberculoid leprosy. The granulomas can be associated with caseation necrosis, and this is the structureless collagen, and the granulomas are seen surrounding this caseation. And caseation necrosis is seen in lupus vulgaris, scleroderma, and other cutaneous tuberculosis. These granulomas can be very discrete and clean without much of the inflammatory cell infiltrate, and such kind of granulomas are called as the naked granulomas and seen in sarcoidosis. Band-like inflammatory infiltrate is the histological appearance which we use in lichen planus and the disorders which are associated with lichen planus. So in band-like inflammatory infiltrate, the first appearance is of interface dermatitis. That is the loss of basal cells and basal cell degeneration. And then there is a lymphohistiocytic infiltrate at the dermo-epidermal junction, which is seen obscuring the dermo-epidermal junction. And this kind of infiltrate is called as the band-like infiltrate and commonly seen in lichen planus, and we see in other lichenoid disorders. In the lichen planus, we use few other terms. The clumps of cytoid bodies or colloid bodies, then a cleft beneath the epidermis, which is called as Max-Joseph cleft, and then this is the pigment which is present in the melanocytes. Due to disintegration of basal cells, the melanocytes, they also get disintegrated, and because of the bursting of the melanocytes, all the pigment which is present in the melanocytes, it goes down into the papillodermis, and this is called as the pigmentary incontinence. Later on, this pigment is engulfed by the macrophages, and then these macrophages are called as the melanophages, and gradually and slowly, this pigmentation is then eaten up by the macrophages and phagocytosed and removed from that place. Choroid lamella or conoid lamella is seen typically in porokeratosis, but also seen sometime in warts and AK. The choroid lamella is actually a column of parakeratosis, not hyperkeratosis, a column of parakeratosis that enters at an angulation into the epidermis. You can see this entering of parakeratotic column into the epidermis, and this is choroid lamella. There are various malignant conditions in which there is complete dysplasia of the epidermis. Full thickness dysplasia is seen in Bowen's disease or in cytomalignancies. You can see the keratinocytes of various shape and various mitosis as well. Mitosis can be seen anywhere. Mitosis can be of different shapes, but it is because of the clumped keratin which is present at the equator during the cell division. And this clumping of the cytoplasm, it is called as the mitosis. You can see these are the various mitoses which is seen in this malignant tumor. Sometimes the tumors comprises of two population of cells. Here there's two population, the pink and the blue cells. And these pink cells, they are typically called as the ghost cells because these cells, they have retained their cell membrane, cytoplasm and cell membrane, but they have completely lost their nuclei. And this is the histological appearance of pilometricoma. Keratin pearls. Keratin pearls are the comprising of keratin deposits seen within the squamous epithelium and is seen in few conditions like in seborrheic keratosis, in squamous cell carcinomas, and in trichoepitheliomas. These are the two cells which I have produced for comparison. These are the squamous cells. Even in squamous cell carcinoma, the squamous cell carcinoma will retain their squamous morphology. What is the squamous morphology? Squamous morphology is the presence of cells with large vesicular or light color nuclei and maintaining the connections by means of desmosomes. Even in very malignant squamous cell carcinomas, these desmosomal connections will be seen. On contrary, the basal cells, which are derived from the basaloid cells and usually maintaining a connection with the epidermis, these cells, they are darkly hematoxylin stained, and these cells, they do not have desmosomal connections with each other, so you can see the nucleus riding over each other. And another feature of basal cell carcinoma is arrangement of these basaloid cells as we see in basal layer of epidermis, and it is called as peripheral palisading. Retraction artifact is another feature which I'm going to discuss in the sections of basal cell carcinoma and skin tumors. So rather, I have already discussed it in my previous lectures. Crater is the large keratin plug which is seen within the hair follicles, dilated hair follicles, and the proliferating epidermis. This crater is seen in keratoacanthoma. Giant cells. There are three kind of giant cells which we see in granulomas. The Langhans type of giant cells, in which the nuclei are arranged in horseshoe shape. If they are arranged haphazardly, it is called as a foreign body giant cell. And then there is a two-tone joint cell, which I have already shown and described in my lecture on xanthomas. Cysts are the round structures which we see in the dermis, and there are two kinds of cysts. The epidermoid cyst, in which the granular layer is retained, and you see the cyst has the reverse kind of cell layers as compared to epidermis. The stratum corneum, which we see in the normal epidermis, is seen in the center of the cyst, and this is the keratin of the stratum corneum, then granular layer, then is the spinous layer. So if the granular is present, then it is an epidermoid cyst, which is called as sebaceous cyst as a misnomer. Then there is a pilar cyst, which we see in the scalp, and here there is loss of granular layer. From the keratin directly, the epidermis starts. Few special stains which you should be aware in your dermatology. So these special stains in dermatology are, one is the Mason trichome stain. The Mason trichome stain is used to stain the collagen, and collagen is stained blue in Mason trichome stain, which we use this stain very often whenever there is a doubt that whether the collagen is protruding out of the epidermis or about the morphology of certain tumors. Then we can go for Mason trichome stain. Then von Giesen stain is a stain which is used to highlight the elastic fibers, and the elastic fibers are stained black with elastic von Giesen or EVG, or we can simply call it as von Giesen. When there is fragmentation of elastic fibers, you don't see these solid staining fibers, but rather clumped or fragmented elastic fibers. Von-Causa stain. Von-Causa stains the calcium, and whenever you are suspecting the calcinosis cutis, we go for Von-Causa stain. PS stain is a commonly used stain for fungi, and here you see the hyphae as well as the spores. The another stain which is used is Grocott stain for staining the fungi. Grocott stain the fungi black. Mason Fontana is another special stain which we less commonly use now because we use immunohistochemistry stains, and Mason Fontana is used to stain melanin. Colloidal iron is a stain which is used to stain the mucoproteins, and similarly is the Alcian blue stain. So Alcian blue stain is more popular a stain whenever we are trying to diagnose the mucinosis. Prussian blue stain stains the iron. So when there is a doubt if the pigment is due to melanin or hemosiderin, we can go for Prussian blue stain the iron black. Oil red O is a stain which is used to stain the fat in the fat cells, but oil red O cannot be done on a paraffin section. It is done on a frozen section. Then certain special stains we use for infective diseases. ZN stain, Zeal-Nelson stain would stain the Mycobacterium tuberculosis, and a modified ZN stain, which is called as the Wade-Fite stain or Fite stain, is used to stain the Mycobacterium leprae. So pink, this ZN stain will appear as pink rods, and we have to see these mycobacterium on oil immersion or 100 magnification. Lepromatous leprosy, the Mycobacterium leprae are seen as clumps, which are called as the globi, and again viewed at 100 magnification. This is a very typical, beautiful appearance of Leishmania trophozoite bodies. These are the intracellular bodies which are seen within the histocytes or macrophages. Immunofluorescence in histopathology. I have discussed about this is the direct immunofluorescence, and I've discussed the different techniques of immunofluorescence in my two different lectures. And here you can see that the appearance of pemphigus is a fishnet appearance or chicken wire appearance. It can be IgG or IgA, but the appearance is that of this bright green is the immunofluorescence, which we see because of deposition of antibodies on particular antigen sites in the desmosome. And in pemphigoid, this kind of staining is seen at the linear IgG staining at the dermo-epidermal junction. This is the salt split, and I've explained the salt split in my lecture on pemphigoid, so you better listen to that lecture. And indirect immunofluorescence, I've already explained in detail in one of my talk that how this procedure is done. Immunofluorescence is used in various serological investigations, like in anti-nuclear antibodies, antihistone antibodies, nucleolar antibodies, and centromere antibodies. So these all are immunofluorescence stains. Cytodiagnosis. Cytodiagnosis is very less commonly used in technique in dermatopathology, but these are the few techniques. One is the Zank smear. You know how the Zank smear is made? It is made by de-roofing a blister and then scraping the roof of the blister 2 or 3 times, and then making a slide from this smear and staining it with Giemsa stain, and you see these acantholytic cells. And if the acantholytic cells are seen, then we can confidently diagnose it as pemphigus, usually done when there is a confusion between pemphigus and herpes. So in herpes, you see these large giant cells or epithelial giant cells. These are not histocytic giant cells, and seen in herpes simplex and herpes zoster. We can go for cytodiagnosis in form of FNAC or smear, dab smear, or salt split or salt smear. And in this, the smear which are made for LT bodies, you can see the small LT bodies within the smear. We see the smear in 100 magnification. Then the last portion of this talk is to introduce you to immunohistochemistry. Immunohistochemistry is a technique which is used to identify particular antigens in tissue sections, and is done mainly to diagnose various skin malignancies. And this technique, we used an antigen antibody interaction, and by this antigen antibody interaction, we are able to highlight various antigens which are particularly seen in certain skin tumors. So this is how the immunohistochemistry is done. This is an antigen. It could be anything, like, for example, CD3. CD3 can be an antigen which is present on lymphocytes, and there is an antibody which binds against the CD3. This antibody can be of any type, can be IgG, can be IgA, but the importance is that this antibody is tagged with peroxidase. So this peroxidase tagged antibody is made to combine with that particular antigen, and I am using an example of CD3 in lymphocytes. And after we are sure that this If the CD3 is present in the lymphocytes, then this antibody will be tagged with lymphocytes, otherwise it will be washed off. And after some time, a particular enzyme is placed in that tissue, and then after some time, this enzyme is also washed. And if the peroxidase is already deposited by deposition of antibodies against the particular antigen, this peroxidase will stain the tissue as brown. And this brown color is seen in the immunohistochemistry stain. So there are different kind of immunohistochemistry stains which we used. Buddy P4 is an immunohistochemistry stain used to diagnose BCC. Epithelial membrane antigen is EMA is immunohistochemistry stain we use in squamous cells. Then CAM 5.2 in certain secretory tumors. Then S100 seen in melanocytes. See, this is CD3 stain, which is seen in case of MF, and CD20 is a stain which we use for B cells, which will be negative, and CD3 will be positive. So we can, with the help of this immunohistochemistry stain, we can make a diagnosis of mycosis fungoides. So I would like to end my lecture here, and thank you for the patient listening. My next lecture will be the algorithmic approach to diagnose inflammatory skin disorders. So thank you all and goodbye.